Hi, I'm Dr. Hill, and I'm the Medical Director for the Aurora EMS system. The purpose of this video is to standardize an approach for CPR choreography that we do. Reason for importance of this topic is that we want to have a standardized process that we do all the time on all of our calls. So regardless of what engine company you're on, what ladder company you're on, or what ambulance you're on, when you get there, your roles and expectations are already established, so you know that when you're assigned to a particular role, that this is how you should be functioning in that system. So we practice a high fidelity CPR model, and part of that is that we all have assigned roles that we're doing within there. The expectations are the same. The most important part of a cardiac resuscitation is good quality CPR. And with that, I mean that we are doing compressions at the proper depth, proper rate, allowing full recoil of the chest, that when we ventilate patients, we are ventilating at the proper rate and proper amount, not over-ventilating them. Doing those things has shown to have significant increases in cardiac survivability. So when we're practicing our CPR program here, we have some changes that we are implementing that we should be doing consistently throughout from now on. One is we are definitely doing a continuous compressions model, okay? Once we get there, we should be initiating chest compressions and doing it continuously, only stopping for pulse checks or if we have to do it to move the patient. Along with that is we are going to doing an active ventilation model. We are not going to be doing passive ventilation anymore. The active ventilation means is that if you're assigned to the airway, you will be doing asynchronous ventilations with a bag valve mask and an OPA while continuous compressions is going on. And once we transition to an advanced airway, we will continue to do the standardized ventilations once every 6 seconds. Also, my expectation is that the cardiac monitors are placed in such an area during resuscitation that the ventilator, the chest compressor, and the lead paramedic can all see what is going on that screen. And if you're the lead paramedic, you need to be looking at all of it and keeping an eye and making sure that the chest compressor that you have on is doing chest compressions. And if they're not, you need to verbally coach them to do it. Or if they're fatigued out, you may have to verbalize that we're going to change rescuers or change chest compressors because that person is too fatigued to continue to do chest compressions any longer. One thing we've also changed is that we do epinephrine at 3 doses now. There's been studies in the last couple of years, particularly in the last year, the Paramedic 2 trial, and what it showed is that the more we give epinephrine, there are downsides. Yes, we can get ROSC more, but we're definitely having more patients that have significant brain injuries after that fact. So what I mean by that is, if I happen to get ROSC on them, the ones who got epinephrine or least epinephrine did better neurologically than those who got lots of epinephrine. So systems across the country are definitely scaling back how much epinephrine we're giving to people. We're limiting it to 3 doses during the cardiac arrest. The only exception to that is if it's a recurrent, if you got ROSC and it's a recurrent arrest, you can give another dose of epinephrine, or if you have a persistent narrow complex PEA, those also have been shown to have increased chance of ROSC by getting additional epinephrine. The main thing with any of our chest compressions is we have to do it in a way that we are minimizing any interruptions. We should never be pausing chest compressions to place an advanced airway of any kind. Ideally, on any given pulse check and rhythm check, we are doing that within a 5-second window, certainly no more than a 10-second window. So minimizing our interruptions absolutely has been shown to increase cardiac survivability. It's also my expectation that we continue chest compressions all the way from the ambulance into the emergency department and do the handoff in a proper sequence, okay? What we see a lot of is either no chest compressions being done between the ambulance and the ER, which is a significant delay in the amount of time we're trying to keep the heart perfused. And also, we're seeing a lot of one-handed CPR, which are really ineffective chest compressions. We need to be doing 2-handed chest compressions all the way from the ambulance into the emergency department to continue that resuscitation and do the handoff in a proper sequence as outlined in the video. Another expectation we have is that we should be working these patients on scene for much longer than we are, and not transporting them if they are most of the time in cold cardiac arrest. Currently, we transport about 80% of our patients in cardiac arrest in the city. So even the ones that are staying for 30 minutes on scene, we're then transporting them. Or we are transporting them much before the 30 minutes on scene. The reason why we have 30 minutes of CPR time is that the greatest chance of getting ROSC in that patient is to do chest compressions on scene. The quality of our CPR is much greater on scene than it is in the back of the ambulance. So by moving them and trying to do en route chest compressions, we're decreasing the chance that we're going to get ROSC on these patients. So 30 minutes on scene, continue that on scene. There's nothing magical about getting into the ER to try to fix that problem. There are some considerations that we may have as to when we might transport that patient after that 30-minute period and not call for pronouncement. Those could include things like the scene is no longer safe. There could be considerations for pediatrics. Okay, I'm not going to fault someone for transporting a pediatric patient in full arrest. Other considerations would be if you have persistent VFib or VTAC. Okay, those potentially have some pharmacological things we can do in the hospital that might get them back. If you have persistent the elevated end-tidal CO2 levels. So if you've been doing chest compressions for 30 minutes, but you're still getting high numbers of end-tidal CO2 back, such as around 30, particularly in patients who have a PEA, those have a much greater chance of getting ROSC. So that's a reasonable chance to transport that patient. They're still a viable patient.
Hi, I'm Maria Mant. I'm your Pediatric Medical Director. I'm here today to talk to you a little bit about pediatric cardiopulmonary resuscitation in regards to your core competencies. I think the most important thing I can relate to you is to remember that children are still humans. And so when we think about the things that you would do in a cardiac resuscitation for an adult, these are the same things that you would want to do for a child. To drill down on that a little bit, what I mean is when you stay in play for an adult, knowing that that is the best chance that adult has for survival, this applies to children as well. We need to stay on scene and do the life-saving interventions that need to happen early before we get in the ambulance and go. I appreciate that this can be difficult at times, but we need to remember that in order to achieve ROSC, we need to attain good quality compressions, attain an airway, get an IV, and do all of these things in order, in the same order that you would for an adult, as the core competencies dictate. When we think about this further, I hear questions about how we think about apneic oxygenation in children. We have to remember that ventilations are key. And so while you can certainly have a nasal cannula going on a child, we still need to do the compression to ventilation ratio for a pediatric patient or for a newborn as is dictated in your guidelines. Your pediatric field guide is your friend. If you have any questions about appropriate dosing, about I-gel sizing, about ventilation to compression ratio, this is your guide to have by your side at all times. On your way to the call, it is helpful to flip open to the estimated weight, the estimated age, and do a quick review within the field guide before you even get on scene. We have in that field guide the important doses and so forth, but then also other triggers such as the NRP, the neonatal resuscitation guideline, as well as your core competencies. And then lastly, I want to give a little bit of a reminder about the I-gels. These are extraordinarily helpful, allow you to fairly quickly move to doing continuous compressions and ventilations, but we have to keep in mind that it doesn't take much torque on this end to pop this little mask out of the airway. So we have to be very cognizant of disconnecting the bag if you need to let go of the bag for any reason, of supporting the neck with a C-collar if necessary after that eye-gel is placed, taping the eye-gel to the C-collar to prevent any sort of flexion or extension that can also pop this out very easily. Another question that we frequently hear, and one that actually has just been addressed in the literature, is in regards to scene management and family management during these very stressful, very chaotic situations. For example, if a family or an on-scene police officer rushes the child who is in full arrest out of the house to you, it can be very tempting to just throw that patient in the back of the ambulance and start driving. And we often think about how that might look to the family if we stay and play. Please remember that there is no life-saving magic that happens behind the emergency department doors, and it is beneficial to the patient to stay on scene for that prescribed amount of time to do your initial interventions, up to 30 minutes of resuscitation attempts before going to the emergency department. And the way that we can manage that scene and that family effectively is to assign someone else to answer the questions to the family. For instance, a company officer or someone not directly involved in patient care. People involved in patient care need to be concentrating on patient care. That person who interacts with the family can then explain to the family that staying and doing these initial interventions is what is best for their loved one and gives their child the best chance of survival. Talking to them about what is happening next, what it is that is going to be done, and then to go on to the hospital. This can offload that pressure and that feeling of we have to just leave to the folks who are actually providing those life-saving measures.
The way that we're going to outline the arrest priorities will be BLS airway for the first 2 minutes. Second 2 minutes will be the initiation of an IV or IO. The third 2 minutes will be medication administration with setting up the advanced airway. And then the last 2 minutes initially will be placement of the advanced airway. And that's the way that I remember it. BLS airway, IVIO, medication administration, ALS airway, to kind of keep the big picture. I think it is imperative that the lead medic also, when the assessment's done and that foundation is set, to be able to step back. And I think it gives great perspective as to managing the arrest choreography.
I want to make a few comments about the core competencies and why they have a timeline listed there. The first thing is that this is really built on having 4 rescuers on scene to do cardiac resuscitation. It gives you a list of priorities and a good format to follow. That being said, if you have additional rescuers there and you can do certain things earlier, that is acceptable. For example, if you have an IO placed early on and you're able to give the medication earlier than what the algorithm shows, that is okay. Okay, you have enough personnel to accomplish that. We do want to keep the intubation closer to the 6-minute mark. Okay, 6 minutes to 8 minutes. You can do it at 6 minutes. What I mean by that is that if you have the ability, you have enough paramedics, you have enough personnel on scene to where you start looking at 5 minutes and 30 seconds, 5 minutes and 45 seconds, you suck out the airway and you visualize and you place it right during the 6-minute mark, that is acceptable. The reason why we don't want to do intubation any earlier than that is that if I can ventilate them by basic means, that has significant advantages. The advantages is that once I intubate somebody, I'm greatly increasing their intrathoracic pressure. And once I do that, once I'm positively pressurizing their whole chest area, what happens is the preload to the heart decreases and the chance of me getting ROSC is actually lower. One reason why you might consider doing an advanced airway sooner than 6 minutes is if you're unable to ventilate the patient through basic means. So early on, the two rescuers assigned to the airway, if they are unable to ventilate that patient over the first minute or two through basic means by sucking, BVM, jaw thrust, all those maneuvers, if they cannot get it in, if they cannot ventilate the patient, that is an indication to go to an advanced airway sooner. But generally speaking, we want to do it around 6 minutes or that 8-minute mark.
Police and thieves in the street.
The role of the compressor initially would to start high quality CPR, pushing fast, pushing hard, allowing for a full recoil, and not waiting for the combo pads to be applied. Once the combo pads are applied, the compressor then would continue CPR, watching the CPR channel. There are 4 components to the CPR window. You're going to have depth, rate, recoil, and then the perfusion indicator. So our depth should be between 2 and 2.5 inches. We'd like our rate between 100 and 120. We want a full release or recoil, so that bar is all the way. And then this diamond, the more full it is, the better the perfusion. There will be 2 people assigned to manage the airway and breathing. One person will measure and insert the OPA, making sure that the airway appears to be clear, and if it isn't, they need to suction prior to inserting the OPA. The second person then is going to insert and hook up the end-tidal CO2 and turn that on, and that must be zeroed out before putting it in line. We are recommending 2-person bag valve mask ventilation, with the person at the head of the patient applying thumbs down technique, while the person at the side of the patient is squeezing the bag once every 6 seconds, taking about a second to squeeze the bag and using about 1/3 to 1/2 the volume of an adult BVM on an adult patient. The person who is ventilating the patient then is responsible for watching the end-tidal CO2 channel, and if there is a sudden change, either increase or decrease in that volume or that number, to make sure that the lead paramedic is notified of that. The person assigned to insert the IO will insert it, flush it, and then when appropriate, when delegated, administer the appropriate medication followed by a flush. The pressure bag does not need to be initiated immediately. Michaela, you're going to move to Mike's position, and Mike, you're going to move to where Michaela is. So,
145.
all right, I'm going to go ahead and charge. Confirming at 120. Okay, come up chest. I have EFib, on clear, everyone's clear, shocking. Mike, start CPR. Here's the screen. Okay. Ben, if you want to go ahead and let's get an IO established. And great meeting out. If you can get that suction set up.
My name is Russ. I like to tell you about myself. Hey, I'm a Libra, overachiever. receiver of the heat from relievers. Hey, back to swing. Rusty rock your best.
45.
Reach along.
Okay, I'm gonna go ahead and charge.
Lunging blows, punching foes with redundant shows.
Coming on out with 150.
Thunder from under.
Charging.
Fungus grows. Tectonic plates shift from sonics. Chronic. Correspondent of that bomb. Gamma powered Indiana.
Okay, everyone clear the patient.
Reaching for the big flames.
Then I've got the fib. I'm clear, you're clear, everyone's clear. Shocking.
Spontaneous combustion.
Okay, resume CPR.
With a 3D BB illustrating the text that you now see fitted to a T.
Okay, Ben, we can go ahead and get the epi loose.
Ugly duckling the swan. Watch the phoenix rise. You've seen the skies.
All right, Ben, I'm gonna have you come up and replace Lee. Lee, if you then want to go ahead and get the air trap set up. Right there. And then we're gonna ventilate once every 6 seconds.
Like Willie Beeman, you beat me on any given Sunday, you must be dreaming. You sound prepubescent. Your mom straight shots while she was pregnant. I said your head was
Okay, stop CPR. Everyone clear the patient. I'm clear, everyone's clear. I have AFib, I'm gonna shock. Shock alert, start CPR.
Air track ready to go.
Air track, okay. Ben, if you could perform suctioning. Mike, let's go ahead and pull the mask and pull the OPA out. Mike, if you want to step back. Okay, your airway looks clear. Ben, if you want to set that bag valve mask up. All right, Ben, make sure the common carrier is on the stretcher and it's ready to go. After our next rhythm check, we're going to bring him in the man sack out to the stretcher. So at 30 seconds, at the rhythm check, we're going to do the rhythm check, shock, no shock, and then we'll get ready to move. 30. Okay, stop CPR. Just get the bag, please. I'm in defib still. I'm clear, you're clear, everyone's clear. We're shocking. Okay, let's go ahead and move the patient to the stretcher. Doc, is everybody here? Everyone's here? All right, this is John Doe, 55-year-old male. Family found him down in the bathroom when we arrived. He was in full arrest, no bystander CPR. We've been working this arrest for about 40 minutes. He's been in defib most of the arrest. We've shocked him a total of 9 times. He's gotten 3 rounds of epi and a total of 450 of amiodarone. We got him intubated with an 802 at 24 at the feet, and vital CO2 has been in the mid-30s, and an IO on the left leg.
We'll finish our 2 minutes of CPR, and then once we
Minute 45. Really short. Monitor. Okay. Okay, I'm clear, everyone's clear. Shock commander, 1, 3, 1, 2, 3. New compressions.
once the treatment plan has kind of been formalized, it should be delegated name specific. I think when we say somebody do this or somebody do that, there creates a lot of confusion as to whose responsibility that is. So I would say, Mike, I need you to measure an OPA. Kayla, I need you to start chest compressions. The more specific the delegation, the more likely it is to happen the way the lead paramedic would like it to happen. I've observed over some of the fires that the first arriving unit tries to give the scene size up and delegation to all incoming companies in one breath. And by the time they're done, they're out of breath and almost yelling. I think that there is a concern on cardiac arrests that the lead medic will be task saturated by trying to do too much as far as the tasks. I think the same thing happens in delegation saturation. We're trying to think of all of the things that we need to accomplish right off the bat. And I look at a cardiac arrest in 2-minute segments. What do I need to accomplish in the first 2 minutes? And delegate that specifically to each person. Michaela, I need you to start chest compressions. Then confirming that Michaela understands that. Mike, I need you to insert an OPA. And then make sure Mike understands that. Lee, I need you to get capnography hooked up and let's turn that on. It's piece by piece. It's a conversation with each person and confirming that they've understood their role, and it gives them a chance to clarify and ask any questions if they need to do so at that time. I think it's very important that the lead paramedic remain calm throughout this situation. The more critical the call, I know I try to speak a little slower and a little softer, that if I am getting excited or I'm feeling anxious and that projects outwardly, I feel the team is going to be the same way. I think we all look to leaders on a scene, whether it be a structure fire, an auto extrication, or a medical call, and the more composed that leader is, the more confidence the team has to be able to speak clearly in your delegation and to be able to then step back and calmly again tell someone, okay, we need to increase the rate of compressions or the depth of compressions. I think it gives a sense of calm in the chaos that we often find ourselves working.